Thank you for having me here to ARVO, the Champilla Mode, and the organizers for allowing me to present this exciting research to you. This is my research funding for the aqueous humor research. So this is the problem. This is retinoblastoma. Most of the people in the room are well aware of this disease entity, a primary intraocular tumor that occurs in little children. And the other problem is that retinoblastoma is one of the only solid tumors that cannot be directly biopsied due to concerns for extraocular tumor seeding that vastly change the prognosis for life for the child. So despite the fact that retinoblastoma research really launched a huge portion of our understanding about cancer genetics, in fact, the Helen Keller Award this year went to 4 people from our society, Murphy, Galley, Drija, and Cavaney, for the cloning of the RB1 gene, which was the first ever tumor suppressor gene. So despite the fact that it was retinoblastoma that opened the door to tumor suppressor genetics and cancer genetics, we have not been able to harness this information for diagnosis, prognosis, or any sort of personalized management in retinoblastoma because we don't biopsy the tumor. So then there has been an opportunity. As you know, in 2012, Dr. Francis Munier described a safety-enhanced technique for intravitreal chemotherapy. And as part of this procedure, an initial paracentesis, a clear corneal limbal paracentesis, is done. And Jasmine Francis and others in a collaborative study have shown that using this safety-enhanced technique, there have been no cases of extraocular spread. So the door presented to us in ocular oncology looked something like that. That's from near my home in Southern California. And so we took this opportunity to evaluate tissue from eyes undergoing treatment, the tissue, of course, being the aqueous, to see what we could find there. So with this safe access, we asked the following questions. Could we identify measurable levels of nucleic acid in this 0.1 cc's of aqueous humor that is taken? Can we reliably and reproducibly identify tumor-specific DNA in the aqueous? And 3, are there any prognostic markers? So the first proof of principle paper was published in JAMA in October. I'm going to go through the data very quickly, but if any of you are interested, I'm happy to give you the paper. In this, we looked at the concentration of nucleic acids to answer our first question, which really, to be quite honest, was, is there anything in there? And we found that, in fact, there's DNA, RNA, and microRNA in the aqueous humor, although most samples had about 0.2 nanograms per microliter. And then we looked at 3 cases as a proof of principle. The first 2 patients underwent primary enucleation, so they had large, untreated tumors. The third underwent attempted salvage therapy with intravitreal injection of chemotherapy and was subsequently enucleated. And let's see what we found. So this is from the first patient. If you can see at the top, the blue is the aqueous humor. The second column, I'm not sure if this is coming out to you guys, but in red is the tumor. And then the third is the overlay between the two. And I hope that you can appreciate, just by looking at the shape alone, that the areas where there are chromosomal gains and chromosomal losses overlap beautifully, excuse me, in this case. Case 2 was a patient who had a 13q germline deletion, clearly predisposing to the development of retinoblastoma, and clinically this patient had multifocal disease with multiple tumor clones. Again, primary enucleation was performed, and you can see at the top in blue is the aqueous with the pattern of chromosomal gains and losses. In red in the second column is the tumor. This is from a buccal swab, simply showing the 13q deletion, and here's the overlap. This overlap was similar but was not exactly alike, which our hypothesis for, and something we're looking to prove right now, is that in fact each separate tumor clone was shedding into the aqueous humor. We see this with other liquid biopsies and other solid tumors. And so in fact, the aqueous as a liquid biopsy represented the overall milieu of genomic changes in that eye. And then finally, this was our most important case. This sweet girl underwent attempted salvage with chemotherapy and intravitreal injection. As you can see here, she had 4 injections, and with every single injection, aqueous was taken. I hope you can appreciate that despite the fact that this was taken over time, the chromosomal pattern of gains and losses remained stable. She had a tumor recurrence and needed to undergo enucleation, unfortunately. However, it did allow us to show that the pattern that we had seen in the aqueous prior to enucleation was similar to those changes seen in the tumor, and you can see how similar they are in overlay there. And so if you look at the compilation of our aqueous humor samples, again, the initial ones to date, and you compare them to a summation of chromosomal gains and losses taken from tumor and enucleated eyes, this is from some work by Annette Mall, you can see that the genomic changes that we found in the aqueous were in fact very similar to a larger set seen from tumor profiling. And so once we understood that the aqueous may serve as a biopsy, we had to ask ourselves, we've treated this disease for a long time without a biopsy, why do you even want one? Well, we wanted to know if there was a DNA or another tumor signature that may be predictive of active, aggressive, or high-risk disease. And further, could we determine the rare MYC-N-driven tumors that do not have underlying RB1 loss? Basically, with this tumor, can we say that there may in fact be a genotype-phenotype correlation? And this, as a clinician, was extremely important to me because I am sure every person who's treated retinoblastoma has the exact same situation that I faced many times, which is that two children come in and they look exactly alike. They're the same age, they have the same kind of tumors, the same extent of intraocular disease. No matter what classification you use, they are classified the same, and we give them the same treatment because that's what we do in retinoblastoma. And in fact, one child does beautifully, very quickly, and the other doesn't. The tumor persists and recurs, and we don't know why. And I would argue that maybe there's an underlying molecular difference between these two tumors. So I'm going to end by moving into our most recent research. I've had a great week, and I'm very excited to say that Molecular Cancer Research just accepted the second paper for publication. It should be out soon, and I'm happy to share it with you when it is. Just please ask me. So our subsequent data has looked at 26 patients, 29 eyes. Of those eyes, 13 required enucleation and 16 were salvaged, and we had 65 total aqueous humor samples and matched tumor samples, and this allowed us to compare these two groups, the eyes that did well and the eyes that did poorly. The first question that we asked is, are there tumor cells in the anterior chamber? Now, we had looked at that in our initial study as well with routine cytology. We did not find any. The spike of the DNA found in the anterior chamber is around 170 base pairs, consistent with cell-free DNA. But we also had the privilege of looking at the pathology for multiple specimens and multiple patients at this point. And not only did we not find any cells in the anterior chamber, but you can see that the tumor tract in the cornea as well as in the sclera was free of that there. In our first paper, we intended to prove that the aqueous humor represents the tumor. Now we have many more eyes to show that, and in fact, of these 13 eyes, 11 had greater than 90% concordance. Concordance is calculated by the fact that where there are chromosomal gains and losses in the aqueous, they are also present in the tumor. And interestingly, the other two cases, one of which I've already shown you, had 85% concordance, and both of them had multiple tumor clones. And you can see that beautifully here as well. Hopefully you can see the overlap and how well that matches from multiple aqueous humor samples. The next question, is the aqueous humor reliable? Well, why does that matter? If my goal is to use this as a clinical test and I take aqueous humor at diagnosis, let's say, and then 4 weeks later, and it's completely different, I don't know which aqueous humor sample to look at. So what we were able to show here with Pearson correlation is that in fact from the same eye, the aqueous humor and the tumor correlated. And you can see here the gray boxes are from within an eye. It was very rare for an aqueous humor sample not to correlate within itself. And in fact, those that did had fewer large level chromosomal amplifications. And for those of you who like to see that in a chromosomal pattern, that's how that is demonstrated as well. And just to prove to you, I realize this is a busy slide, but this is a big, beautiful screen. Just to prove to you that, in fact, it is not as though all of the eyes that were enucleated had lots of chromosomal changes and all of the eyes that were saved had flat profiles and didn't. I just want to show you these are our initial aqueous humor genomic profiles from each. And this is a representative case. of an eye that was enucleated and a chromosomal evaluation, a genomic evaluation from an eye that was saved. And so then we wanted to, again, compare these two groups. So these are the compiled profiles. And we looked at known areas of chromosomal variations in retinoblastoma. And I hope that you can see here that if you look at the compilation from the enucleated eyes, which are in red, compared to those that were saved, which are in blue, there are a few differences. You can see that, of course, in 1Q, but very significantly, you can see an amplitudinal difference in 6P gain. So the next question was, okay, you can detect a difference. Does it matter? So what we looked at here were ocular survival outcomes. And if you look at these Kaplan-Meier curves, the first is done simply by the IRC classification, and you can see that they stratify. But if you look at whether or not any of those chromosomal changes are present, that stratification and prediction for which eyes will do well and which eyes will do poorly is better. And that is driven primarily by this gain of 6P. And so again, if you look at all eyes here, you can see how significant gain of 6P was in predicting which eyes would do poorly. And that's even seen within group. Now, most of these were advanced eyes, but if you take the group D eyes or the group E eyes and you stratify them by whether or not any of these chromosomal changes were present, you can see that the stratification and the prediction for clinical outcomes was in fact better. And that is the same whether or not you look at all eyes together, as we've done here. This is the presence of any chromosomal abnormality. And then again, this is the 6P gain, which is driving it. And whether you classify by the Children's Hospital Murphy classification or whether you use the TNM classification. And again, driven primarily by 6P. We found that 6P gain was associated with a 10 times increased odds of enucleation in this group. Now, I'm very frequently asked, well, you're looking at multiple factors, what is the role that plays? And I would argue that we don't exactly know what the role is of gender or age or the interaction of these various chromosomal changes. However, if we just say there may be some interaction and we control for all of them, in this small data set, there was still a 2 times increased odds of requiring enucleation for eyes that had 6P gain. The final question we asked are sequential samples informative? Do you need just one sample and that will give you information? Or in fact, is it helpful to sample the aqueous throughout the course of treatment? And so what we found here are, this is 2 eyes, 1 eye that did well, and 1 eye that did poorly. So on the top here, I hope if you just look here, you can see that in these areas of chromosomal change, there was an initial response to therapy, a decrease, likely a decrease in the overall concentration of cell-free DNA in the aqueous humor in response to therapy, as well as a normalization of these chromosomal anomalies, which then later increased as the eye went to enucleation. Versus case 22 down here, where you can show a steady decline in these chromosomal changes as the cell-free DNA, again, normalized, and this eye did well. So I realize this is only 2 cases, but it is suggestive that longitudinal sampling may be helpful and may help us find either persistent or early recurrent disease. So, in conclusion, to date, we have identified tumor-derived cell-free DNA in the aqueous humor of retinoblastoma eyes, and we've been able to show that retinoblastoma-related copy number alterations, particularly gain of 6P, may be a driver of a more aggressive phenotype for retinoblastoma. And there are a lot of questions that remain unanswered, which include the role of the aqueous humor in diagnosis and prognosis. Do smaller tumors have sufficient cell-free DNA for evaluation? Remember, most of these were advanced eyes. Retinoblastoma is a necrotic tumor. A smaller tumor may not show that to us. Is it possible to determine the RB1 and the MICN status from the aqueous humor? And are there other clinical associations that we can make? Can we tell from the genomic evaluations or other markers whether or not this is an eye that has high-risk pathological features, or is it associated with seed class or other response to therapy? So we are working towards a prognostic assay for eye salvage and retinoblastoma. We do think that 6P may play a role in a more aggressive phenotype, and we have just been approved for multi-center collaboration. So I would love very much to collaborate with any and all of you who do this routinely and take aqueous humor paracentesis already in your retinoblastoma patients. Thank you for sticking with me before the wine. And I hope to see all of you in Los Angeles in March at the International Society of Ocular Oncology.